Okay, we're in the home stretch. If you feel like you need to stand up and stretch briefly, because we are gonna kind of come around and return a little bit to some of the concepts that Tracy presented earlier. So I was really excited to see that, as well as this epidemiologist in me is really excited to see these nuggets of fabulous science and evidence emerging from the research centers. So the evidence base for children's environmental health and the mindset and practices of clinicians who take care of children, who take care of pregnant women or families contemplating pregnancy don't overlap very much right now. And I'm going to start with an example that illustrates, I think, some of the things we need to think about when we think about how we might do this better. And I'm going to start with an example where we actually have probably one of the most mature evidence bases for the relationship between environment and child health, and that's asthma and environmental triggers. So back in 2000, we have this publication of a sentinel piece of work from the National Academy of Sciences Institute of Medicine panel looking at the state of the science on indoor air pollutions, a little bit on outdoor air pollutants, and exacerbation of asthma or incidence of asthma. And in the decades since then, ongoing research contributions, including actual randomized controlled trials. We do have that in environmental health, actually, in terms of intervention trials to see if, okay, we know some of these things look like they have an effect on asthma. What if we take them out of the picture? What if we do interventions? Do we have an effect on asthma status or disease in children or adults? And it all, with that kind of maturity of evidence, we have production of actual guidelines from NIH and NHLBI suggesting what the optimal standard of care and best practices for care of asthma should be, and that gets distilled down into 6 priority messages, including one of those 6 is all about identifying environmental factors and reducing those exposures that patients with asthma might be sensitive to. And this is kind of what it looks like. This is actually a little bit like that sort of Cochrane idea where evidence gets evaluated and rated on a scheme of, in this case, A to E. And in fact, for the NIH guidelines, they do have evidence for these environmental factors that meet the A criteria, which is RCTs, a number of RCTs, the gold standard for showing an effect on a reduction of asthma symptoms and disease status with control of environmental triggers. So how are we doing in clinical practice? Well, I've been involved with a project through the National Environmental and Education Foundation, funded by a grant from EPA, to try to bring some of this information into clinical practice through standardized training modules. So a number of us at medical schools are so-called asthma faculty champions, and we do these standardized trainings to our fellow colleagues and other physicians in our communities on environmental management of asthma, and it includes some kind of toolkit type materials to try to make it easier and accessible for the busy clinician. But at the outset, before we do these trainings, we do a little survey on where physicians are in terms of incorporating these things or thinking about things in their practice. And what we see is in the last few years, we've been doing this for about the last 4 years, that it's not really playing out in clinical world. The number of clinicians that we train at the beginning, we ask them, do you always ask your patients with asthma about these environmental triggers? And you see we do okay with tobacco smoke, but for most of the other ones, a pretty poor job. And not surprisingly, since they're not asking, not surprising, they're probably not asking the question because they don't have a lot of comfort level in discussing these issues with their patients. They're not comfortable advising patients about secondhand smoke exposure. They don't know where to find information on environmental management of asthma, and they're not comfortable teaching patients about controlling asthma. So they're not going to go there if they don't feel like they have an ability to address those issues. So why have we not done a better job of incorporating the body of evidence of children's environmental health, especially in a case like asthma, where we have such a richness and depth of information to work with in the clinical realm? I think there's a number of important barriers, and I've tried to sort of organize them here. And one of the areas I think it falls into is the culture of clinical training and how clinicians are trained and how they identify what their job is. And in pediatrics in particular, and that's sort of the world I know the most, and so I'll be speaking mostly from. The standard training in medical school contains almost no components of children's environmental health. And we don't have a specialty of pediatric environmental medicine, unlike if somebody's provider is dealing with a family that has some issue that they feel a little bit out of their comfort zone. They like to have a backup. They want to be able to call the specialist in the pediatric pulmonologist or cardiologist. There's not that pediatric environmental medicine specialist at the ready. And because of this, there's a real lack of ownership of taking on these issues and this evidence base in practice. And even when there is good information, solid science, and the packaging and delivery of that to the clinical community is, I think, another very important issue, and maybe what we've seen a little bit with the problem of seeing better environmental management of asthma. So what does this training gap look like? A survey of the medical schools in the United States, this is a little dated, I couldn't find anything more recent, it was published in '96, but it was a good response rate. 94% of all the medical schools responded. At that time, 24% had absolutely no environmental medicine content, and those that did had on average about 7 hours in the full 4 years of medical training. That's everything, that's asbestos, that's adult occupational stuff, as well as child environment. A more recent survey looked at what about the next step of training of after medical school, if trainees are interested in becoming pediatric providers and participating in a pediatric residency program. A lot of that curriculum is run and overseen by the chief residents. A survey of the chief residents published a couple years ago asked about the content of pediatric residency training for the sort of the key in children's environmental health topics, which are listed here. And again, you see a pretty overall poor track record for addressing some of the major issues like lead, environmental allergens. You see for things, emerging topics like endocrine disruption, 2% of residency programs have some kind of content on that in their training program. So additional barriers besides training, again, is this issue of role models or specialists, or even if you're not getting it in the standard training, are there opportunities for these trainees to participate in special projects or opportunities, say at the local health department, at the regional EPA office? Those opportunities are pretty minimal for medical trainees. And if someone is interested in becoming a specialist in this area, and gaining that special expertise, the common pathway in medicine specialties is to do a postdoctoral fellowship. And currently, the number of opportunities for that are very, very limited, and I'll have another slide on that in a moment. And even for physicians in practice who are looking for an update or a little information on these topics, looking for those continuing medical education opportunities, there are few offerings, but they are also very sporadic and limited. In terms of specialist training, they're the very first formal directed pediatric environmental health fellowship training program was introduced in 2001 and ran for 4 years with some foundation grant funding led by the Academic Pediatric Association. There were programs at 5 universities. And unfortunately, once that foundation funding and that special project went away, only 2 of the programs have been able to maintain pediatric environmental health fellowship training in a formal way with follow-on federal funding. So again, there's really 2 programs that a pediatrician or another clinician may go to get this kind of specialty training today. So not surprisingly, out there in general practice, surveys of pediatricians demonstrate that they really, they don't have this training. They're not familiar with how to take an environmental history. I was interested in Washington State because it's such an important agricultural producer, and we have a number of research studies. I was interested in doing some outreach and education to the clinical providers in our farm worker clinics, and so surveyed them on kind of what they knew about pesticides. And I was surprised to find in that special population, with day in, day out, they take care of the farm working families who live, right next to orchards that are heavily treated with pesticides. About 57% said we had any kind of pesticide health training, and that was really mostly occupational acute poisoning training, and only 30% had any kind of child-specific information. Other barriers that come up, and this is the requisite Gary Larson slide, says, Mr. Osborne, may I please be excused? My brain is full. So I don't know about you, but sometimes you feel like you're drinking from the fire hydrant in terms of the kind of information coming out, just keeping up in the environmental health research realm. But for busy physicians, of course, you're competing with other areas of discovery and science and needs that they need as well. So there's some of that. And then there's also, within that fire hydrant of information coming out, it's, the good quality science, like some of the stuff we see presented today. And then there's, everything you can find on the web and other places, including what I call charlatans or, so-called experts that will tout themselves as experts and provide, advice on diagnosis and treatment that has no basis in any kind of evidence-based paradigm. So there's competition with that. These kind of sources of information often come much easier for the communities and patients than finding that specialist or expert or somebody who knows something about these, what we really know in the data. So there's a lot of limitations, but I think there's a lot of hope, too, because especially in the pediatric world where I come from, I find that clinicians are extremely motivated and interested because this is everyday life. The patient who has an asthma exacerbation because suddenly they're using a wood stove, the family that asks about, is this sunscreen safe? This is everyday routine pediatrics, and when you survey pediatricians, and this is data from Wisconsin, but it's been done in many states, over 90% say, yeah, I see patients with environmental health problems. And yes, I'm interested in learning more about them. And it's not a tough sell, and it's an easy audience because they come with a lot of the building blocks of some of the paradigms in children's environmental health that we're all familiar with. Children are not small adults. They have unique behaviors, and this is, again, the way clinical providers are used to thinking about drug dosing based on weight or surface area, specific anticipatory guidance based on developmental status of a child. And they're also used to thinking about children in the sense of community health and focusing a lot on prevention and anticipatory guidance. So we'd like to see an overlap of what the children's environmental health research contributions have to make with what goes on in the minds and practices of clinicians. We'd like to see that when clinicians are taking those environmental histories, oh, by the way, they're asking about the home setting, asking about the community setting. We'd like to see that when clinicians are taking care of patients with asthma, they are equipped with the tools to take on environmental management as one of the core pieces to best care. We'd like to have them have at their ready, when they're deciding at a particular time in a visit, which routine anticipatory guidance they're going to focus on in their repertoire of things, along with safety and other seat belts and other usual suspects. They have the children's environmental health information and messages, so that they may discern may be also just as important or more important at a particular visit. And they have access to local and national resources, and particularly I'll talk a little bit about the PEHSU program. So they have an ownership and an efficacy. There are a lot of a few, I guess, not a lot, a few tools and organizations out there for clinicians. And probably one of the most important is the American Academy of Pediatrics, Council on Environmental Health. They publish this thing called the Green Book, which is kind of, the thing you can grab off your shelf and open up to a chapter on a particular exposure or a setting. It's got sort of the core children's environmental health topics, and the new 3rd edition was just published and is now available. And in addition, there are a number of statements that are published in the journal Pediatrics that come from that same council, and that includes technical reports, which are systematic evidence reviews, state of the science on topics of interest, as well as policy statements that often partner with those technical reports that say something about what clinicians should be doing with this information, as well as what policymakers should be thinking about with these issues. Other government and non-governmental organizations that have been really useful in terms of producing information materials that might be shared with patients, in particular is CDC's ATSDR and EPA and the Collaborative Health on Environment. The PEHSU program this is really a lot of the mission of the PEHSU program network, so I want to take a little time on that. The Pediatric Environmental Health Specialty Unit is a program funded by CDC and EPA to provide regionally based expertise on these issues at academic centers. So there's one in every federal region. And the mission is there to improve the environmental health of children by enhancing education and consultation services. And the primary audience of the PEHSUs and kind of the unique niche that they fulfill is reaching the clinician audience in particular, as well as other public health and health professionals. Some of the approaches that the PEHSU program has taken to try to increase this capacity of general clinicians to take these issues on is sponsoring conferences and events, things like this, but that might come along with continuing medical education or nursing credit, sponsoring journal clubs, publishing fact sheets that are specific to the clinical audience. So it's easy to find information sheets and fact sheets for general topics, but it's hard to find advice that speaks to what clinicians really want to know. And some of that is around, you know, do I need to do any kind of medical testing? And if I did, what would that look like? And how do I talk to patients about these issues? Each of the PEHSUs have their own websites, as well as we have a national website with some core information. We publish review articles in clinical journals, and importantly, provide that peer-to-peer consultative service. And we involve trainees at every level in our program work to help with that pipeline to build the capacity in this area. And sometimes that involves also working with our local health department, our state health departments, or our local EPA on special projects. So I wanted to get people starting to think about how we might expand some of the small partnerships that have begun between the PEHSU network, the Children's Research Centers, and public health agencies, because there is overlap in some of this mission in making sure that some of this work that gets done in the research realm or in the policy realm is translated to the clinical community and to the community at large. The PEHSU program has some experience and track record in this, but this is we are a very small program. We're underutilized, and like everybody else, we're under-resourced. So the idea of, working together to maybe do more better with less. So I'm going to, my last slide is right after this, and it lists some examples to kind of start getting, thinking about how this might look. But before that, I just want to remind us and to take a moment to remind, why it's important to engage the pediatric clinical providers, as well as others like the OB community that Tracy spoke more to earlier, and other types of providers out there that deal with families and children. It remains to be one of the most trusted source of information for the public or study subjects. They're generally considered unbiased and having a balanced viewpoint, whether or not that's true, but that is the perception. And I think the other thing clinicians sort of have going for them in this realm is that they're used to not having perfect information and evidence and making decisions and talking through these issues with families. And I liked some of that paradigm that Tracy was talking to, that sort of sense of the value judgment and making it individual. And this is something that clinicians are used to because, again, that is everyday life. A lot of the stuff done in medicine we don't have great evidence for. And so being able to have that conversation and making those choices and informing, talking to families about that is something that they're used to. And translates well into the environmental health realm, where we often do have imperfect and not quite enough information. They're influential at the community and policy level, and they can inform the scientists among us on really what are the important gaps, needs, and emerging issues that need to be addressed, and sometimes get us out of the ivory tower. So what are some examples and approaches that might be taken to combine forces to improve upon the capacity of the clinical audience and really just to augment what each of us brings to improving the environmental health conditions of children? One of the things is to think about materials that translate new policy measures. And up in the Pacific Northwest, PEHSU was approached by the Portland community through their department, the state of Oregon Department of Environmental Quality, because they have a pretty state-of-the-art air toxics assessment modeling program that's been in place, and they've got you know, a lot of information now on what the air toxics look like in the Portland area at a pretty fine spatial scale, and they've been, you know, trying to get the information out to the public and explain this and work with it. But they came to us because they realized they really didn't know how to approach the clinical community, and they figured that, you know, this is a good way to get the information to the general public because there may be questions to clinicians. It's an awesome opportunity to educate clinicians and, again, get that ownership about environmental factors in health. Oops, sorry about that. Here in California, you might start thinking about the Green Chemistry Initiative and how to get some of that information and get some ownership of that in your clinical communities to make gains in areas you want to in that program. The PEHSU network co-authored articles in a dedicated journal of the Pediatric Clinics of North America in 2007 on a number of important topics in children's environmental health. I'm wondering if today, you know, now it's 5 or so years later, if it's time to think about updating that and thinking about, is it time to think about translating, you know, approaching some of these journals about a special product, saying, okay, what have we learned about pesticides in child health from the Children's Environmental Health Research Centers, and what does it mean for you pediatricians, family doctors, et cetera? And other things we've done is sponsored journal clubs and grand rounds, so going to the places where these clinical audiences routinely go to get their update and information. We are going to have an event like this up in Washington and Seattle next month, and it's going to be continued, not only an in-person one-day event, but we're going to sponsor bi-monthly webinars to keep the community of researchers and public health agencies and PEHSU kind of on track with what each other is doing and increase connections. Developing research findings, topical fact sheets. Right now, we've been asked to work with the Department of Health on topical fact sheets so that legislators who, you know, something comes up, a new bill, a new idea, and there's not enough time to really get them up to speed on getting their buy-in on why this is important in the first place. So doing a little of the work before to make sure that they, you know, have a better understanding of why these issues are important so that when special initiatives come on, it's easier to educate them and get them on board. Returning research results to study subjects and their clinical communities. I think that's something that the PEHSU network can be very helpful with, working with researchers in particular. And thinking about how you might involve clinical trainees in your research programs and in your public health projects and programs, so we can have that cross-fertilization and increase the sort of sense of identity and specialty within the clinical realm. So I think I'll stop there and wait for questions in the panel and help us get out back in the sunshine. Thank you.